Thank you, Dr. Mazen. I think we may have like 1 to 2 minutes, 10 minutes. طيب. So we have a few questions here. One question is for Dr. Mohammed Shafik. Any limitation to wavefront treatment? In what scenario we need to avoid wavefront treatment?
This is really a very good question, because you can never depend on a wavefront treatment except if you have a repeatable and a reliable map. If you're designing to correct or to regulate an irregular cornea, the cornea, as we know, generates a lot of profiles depending on the machine that you're doing. And the key point of success is that you have a repeatable and a reliable map. Sometimes the aberrometers are very deceiving. If you're not able to read the irregular cornea first, through the irregular cornea, of course, because it's a total corneal aberrations, or the total ocular aberrations, I'm sorry, and to have a repeatable map that you can depend on generating an ablation profile, never go for this direction. So you select one of the topo-guided ablation profiles or a corneal wavefront guided ablation profile. And the corneal wavefront guided ablation profile is a kind of a refined topo-guided ablation profile. It simply depends on the corneal data and not a total ocular wavefront data.
I just want to add a little bit, something which is obvious, of course, and just not to outlook the obvious. The other situation that I definitely would avoid any form of wavefront guided ablation is touch-ups after premium intraocular lenses in phaco. So if you implant, for example, a trifocal intraocular lens and you end up with an ametropia or an astigmatism and you decide to do a laser vision correction for this patient, never do a wavefront guided ablation, or else you will negate all the spherical aberration that has been produced by the premium intraocular lens, and the patient will lose the benefit. So this is something.
Yeah, this is a very nice point also.
Next question here. Would you do a PRK for hyperopia, and what is the maximum treatment target? What's your opinion?
According to the classical teaching, hyperopic PRK is totally negated. But sometimes you are too squeezed to do that, especially if it is a little bit of hyperopia. So if you try to correct, for example, +3 or 4, it will be a hell of a case, because many things. First of all, the epithelium will not climb the hill that you created. The second, the healing pattern will be very absurd. The third, the regression will be too strong. The fourth is that you will have a haze. But sometimes you don't have enough thickness of the cornea, or you don't want to create a flap, and you have a very low hyperopic error, like +1 or something like that. And I've tried this, and it works.
Your opinion?
I totally agree, and I a little bit disagree. So hyperopia has been my backyard since forever. My PhD back in the day in 1997 was a comparison between whole myomiac thermokeratoplasty and LASIK for hyperopia. Yeah, so definitely surface ablation for hyperopia was something that was taught not to be done, because you do have a lot of haze post-operatively, and the results of regression are through the roof. But the thing is, recently, with the new, and this has been a debate going on between me and Dr. Shadi Awad a lot of times. Shadi Awad does all his hyperopic patients with a surface ablation. And when I tried doing...
All of them?
All of them.
Even the +4 and +5?
No, he stops at +4.
Yeah.
He stops at +4. Yeah, so, and he doesn't have any preference for lamellar refractive surgery over surface ablation. And the reason he's saying this is that the pattern of ablation now, and the spot size and the Gaussian configuration of the laser spot is being much, let's say, smoother on the cornea and much gentler on the cornea, and it doesn't provoke as much epithelial response as previously. I've tried, I'm not a big fan of surface ablation with hyperopia, but I've tried it. And I've tried it in patients +3, and honestly, it works.
Yeah, it works.
It works.
But the expectation, you do not, I mean, the percentage of failures in many forms, like the induction of haze, the regression, and the abnormal epithelial patterns are very high. So it works, yes, but it doesn't work in 100% of a patient.
The thing is, now this I totally agree, this is classic teaching. But the thing is, we do not have that amount of high probes in our practice that we can actually build evidence based on them nowadays, but definitely doing surface ablation with the modern platforms for high probes is a different animal than the surface ablation, the PRK that we used to do for high probes when we started.
Yeah, but our message for the beginners, never try hyperopic ablation by surface ablation, except it's for very minute errors. But of course, you should refrain from doing that in high errors. It needs an expert.
Actually, I would a little bit agree with Dr. Mohammed Hosny. I've tried hyperopia treatment, surface treatment for hyperopia, and patients are doing fine, even with the long-term follow-up with light and the MIL90, the Zeiss.
And you're happy with that?
Yeah. But as you mentioned, you should not go to the higher
For the beginners.
Yes.
I mean, yeah.
I think I would add one more question. There is a question about the using a trial of contact lens before you are doing your hyperopic treatment. Just to know, would you go with the cycloplegic or the manifest refraction?
Oh, it's an advice to go for the cycloplegic refraction, of course, because even if you induce a little bit of myopia afterwards, you should teach your patient, especially if he's young, that you should treat the total error, because he will come back with a regression between brackets, which is not a regression. It's just the release of the ciliary body after some time. I mean, when it relaxes. So the intention is to treat the full or to correct.
You would not advise doing a contact lens trial. You go just for cycloplegic refraction.
Yeah, yes, of course. But I usually nowadays I'm very skeptical to do a wavefront guided ablation for all hyperopic patients, simply because, first of all, yes, this is the spherical ablation, number one, but because of the compensation for the angle kappa, which is a very big issue in hyperopic ablation. And again, a good aberrometer has a very good fogging that can mount up to the cycloplegic refraction readings without any cycloplegia.
Yeah.
I mean, it can measure the cycloplegic refraction without any cycloplegia.
Would you do the post-Moderator test just to see if the patient's accepting the full cycloplegic
But they will not
refraction
accept. They will not. I mean, simply they will not, but you have to explain to them that you are going to correct fully the cycloplegic refraction, and they might suffer from some myopia afterwards. And there is a very small trick that I give them, a mid-rear seal at the bedtime every day for 2 or 3 weeks. And the ciliary body tone relaxes afterwards.
I think the next session moderator is here. So I would conclude in that, and I really thank you for the nice session, and thank you, everybody.